So today in today's webinar, I want to talk about really about statistics and as it relates to cancer, because that's what we mostly do here at Brio. And when you look at statistics, there's a lot of shock about it. There's a lot of truth, but there's a lot of fiction about it as well. And so we want to talk through that. And I hope to empower you to better understand the statistics and really highlight some recent events, if you will, that will really help us to walk through that together. At Brio-Medical, we are a holistic integrative cancer healing center here in the beautiful state of Arizona in Scottsdale. And so we approach things holistically and integratively to not just target a tumor or cancer, but to actually heal the body. We're not just interested in 1 year, progression-free survival. We're interested in decades of healing. I'm the medical director here. We have a great team beyond myself. We have Dr. Walter Kim, we have Dr. Tam Spat, and we have Dr. Miranda Labont. We have 2 naturopaths and 2 medical doctors, and I am the medical director here. So let's go ahead and dive into the statistics in medicine, specifically fact or fiction, and let's walk through this together. So when we look at statistics, what we really want to do is we want to cut through the modern day fog of the scientific medical research that's out there, because I think there's really no other better way to describe it than fog. Today, and over the last many years, you've heard trust the science, it's the mantra. And understood in that trust the science mantra is trust the numbers. And these numbers they're the pillars of science. But are these numbers solid? What do they even mean? Are they validated? Are they reliable? Are they powered? Are they properly applied? Are they clinically applicable? Just simply quoting numbers doesn't really provide any benefit to a patient in the treatment of cancer. And that's what I want to really highlight here as we walk through. So let's first focus on a study that's not really focusing on maybe fictional or inaccurate or fraudulent material, but actually a misrepresented and misinterpreted study. This is back from 2004. It's looking at chemotherapy as an adjuvant in 5-year survival in cancer. And they looked at 22 different cancer types. And they were looking for 5-year survival benefit from adjuvant chemo. Now, what they found is that in 13 of the 22 cancer types that they looked at, there was a 50% benefit in 5-year survival benefit. Now you go 13 out of 22, 50%. Wow, that's incredible. 5-year survival benefit. What happens is most people hear 50%, they think 50% cure. They think 50% improvement in survival. But let's get a little bit more deep into the details here. In only 3 of the 13, so only 3 of the 22, did the 5-year survival benefit reach, wait for it, 10%. 10%. So that number, 50%, is actually just an improvement in 5-year survival in 10%, and it's only in 3 of the 22. Now the numbers you see here to the left of your screen is 2.3 and 2.1%. This is overall, the 2.3% was in Australia, overall improvement in 5-year survival rate, and in the US it was 2.1%. Let me make this real. Breast cancer, overall the 5-year survival benefit of adjuvant chemotherapy in breast cancer was only 3.5% benefit. Now, this study was 18 years ago, but it shows you by just simply looking at the numbers themselves can be deceiving without understanding the context of the numbers. What are the numbers reporting? What are they pointing to? It's not just the numbers, it's what are the numbers telling us. So this is a quote here that is often incorrectly attributed to Mark Twain. There are liars, there are damn liars, and then there are statistics. The point here is simply that statistics are something that you need to really check twice, because they can often be deceiving. So here's a current event. You probably heard about this if you keep track of current event affairs as it relates to cancer. This was published, you can see there, June 16th, 2022. The title, Unheard of Immunotherapy Drug That in Trial Cured This Cancer Every Time. Cure. Now, first, I think we have to ask the question, is the word cure, is that a valid clinical endpoint? See, when you look at research, there's really three things that we can look at. There are what are called patient-centered clinical endpoints, there are what are called tumor-centered clinical endpoints, and there are what are called surrogate endpoints. Cure is not in any of them. It is not a valid clinical endpoint. Yet here, in the very first part of this press release, they said 100% cure. They also used other phrases or words such as unprecedented. We never ever say that about cancer treatments. These are statements that were in the top of this article talking about a drug, an inhibitory drug, called dostarlimab, a immune checkpoint inhibitor, and they were using it in 14 patients with colorectal cancer. So they mentioned cure, they mentioned unprecedented, they mentioned we've never seen this before in cancer treatments. Yet, if you dive your way deeper down into the article, because they know you're not going to dive deep into the article, you actually find that an author that they're quoting in there actually says, well, at 6 months, all 14 have no evidence of disease. Yet, at 25 months, only some of them have no evidence of disease. So cure? No, not a cure. Not designed to be a clinical endpoint. Really what this was exciting data, no doubt, because it was really allowing us to see the possibility of a future therapy. But the sensationalism, the hyperbole that was presented here as cure is inaccurate. The verbiage that they used at the top was inaccurate. It was misrepresentation. And out of that, people are going to misinterpret the actual validity of this drug. And often when you look at these drugs, the first thing that you're looking at in phase 1 clinical trials is simply, is the drug safe? Not really its efficacy beyond anything beyond that. So let's tie this back to the 50%, the 13 of the 22 from that 2004 study that I mentioned. So if we look at that 50%, as I mentioned, it provides an interpretation bias, meaning the person that's hearing it's going to misinterpret the data based on their own inherent bias. So in that, does the 50% mean, as in this case, cure? Does it mean just simply 50% time to next treatment? Does it mean 50% increase in objective response? Or who or any family thinks about 50% in terms of clinical control rate? But really what we're looking at is just a 50% of any benefit in 5-year survival rate, any benefit. And as it relates to breast cancer, 3.5%. And in the US overall, in these 22 cancers, just 2.1%. So these numbers clearly have to be put in proper context. So here we are with Mark Twain. Facts are a stubborn thing, but statistics are pliable. So this is correctly attributable to Mark Twain. And that pliable word I think is very interesting here because it implies flexibility. Yet statistics and numbers really represent not flexible. Pliable also means easily bent or easily influenced. So easily influenced means it doesn't stand strong. It doesn't hold its ground in times of scrutiny. And statistics and numbers should. So here was another recent current affair or event. And this was published, interestingly, June 21, 2022. And you can see all of these very recently. Now, this actually followed by one day a study, an article I'll present in just a second. But this article here said, vitamins, let me scroll in. Vitamin supplements are a waste of money. Experts warn there's no proof that multivitamins can prevent cancer or heart disease. Now, this is really a retread of many different articles where they've written about this, but the authors here have a gross misunderstanding of the difference between multivitamins and vitamins. They have a gross misunderstanding of not utilizing bioavailability, pharmacokinetics, pharmacodynamics, or proper dosing as it relates to vitamins. They are using multivitamins and extrapolate it to all vitamins, whether they're used therapeutically or not, whether they're used orally, whether they're using them IV. This press release, providing no link to the study, is actually really diving into misinterpretation and misrepresentation bias as it holds. Just some confusions that they had here. They said, one, micronutrients and isolations may act differently in the body than when naturally packaged with a host or other dietary components. Interestingly enough here, if you have low potassium, the doctor is not going to give you a multivitamin or a multimineral. He's going to give you potassium, and in many cases, IV. So the context of giving micronutrients individually, like potassium or sodium, that exists. Vitamin C, vitamin A, vitamin E, and beta carotene contain antioxidants that were once thought to help reduce cancer. Okay, they are still known, particularly vitamin C, to treat cancer, but you have to dose it in a way that allows it to act pro-oxidatively. And if you look at the prior webinar where I talked about vitamin C high dose pro-oxidatively, but orally it's antioxidative, this author clearly hasn't read that or doesn't recognize that research. So, and they looked at scientists from a Northwestern University in Illinois backed the new guideline in an editorial in JAMA, which is Journal of American Medical Association, telling them to stop searching for a magic set of bullets to solve their medical woes. But yet in that previous press release, which by the way had no link to the actual study because it wasn't published, but they were advertising, they were marketing another set of magical pills. That just happened to be a drug. But they're saying here, hey, don't use these magic pills, but use ours. So again, when you look at this concept of multivitamins, another quote here says, the task force is not saying don't use multivitamins, but what they're saying is really don't use them. Use what we recommend. And it's really interesting, again, because when you look at the science behind something like vitamin C, like something like vitamin D as it relates to cancer, the science clearly points to its benefit in the treatment of cancer, but you just have to treat it with proper knowledge. And if one just takes a multivitamin, I would tell you that's not going to help cancer. Yet here what they're going to do is they're going to disguise it with U.S. Preventative Service Task Force. They're going to disguise it with JAMA. They're going to disguise it with new guideline and an editorial. And they're going to take what appears to be science and is really nothing more than a press release that's thinly veiled as science. Another great quote here, and I think it speaks for itself. In ancient times, they had no statistics, so they had to fall back on lies. And again, I don't want to pound numbers or pound science and say they're all wrong. I'm just saying we have to take a discerning eye to every number and every statistic that's quoted, because every human is by nature biased, and we have to recognize that. So here was the article that was published basically one day before that multivitamin article I mentioned. And they do use some hyperbole here, fair enough. It was actually a press report, but presented very differently than the other two. This one here actually linked to the published article published from Oxford University, very prestigious university. The title, Bombshell Oxford Study, less than 6% of approved medical drugs are backed by high quality evidence to support their benefits. Harms are significantly underreported across the board. Now, this study that I'll show you in just a second, it very clearly mirrored a more recently published article, a published article a little bit longer ago that actually looked at what was happening in the US is a lot of studies were being fast-tracked. I think I've heard that before, fast-tracking studies to get therapies to market. And what was happening is they were not using good supporting evidence to do so. They were using more of what's called surrogate markers, of which most have not been clinically validated to be utilized. And in that article, they actually showed that, quote, increasingly accepted less data and more surrogate measures are being used. And so when we look at this study here, we see that 94% of approved medications do not have high quality evidence. And in fact, just a little bit over 50% of them failed to meet even moderate quality standards. But yet when people, and doctors are also included in this, when we look at evidence, when we look at numbers, when we look at quote unquote conventional therapies, standard of care therapies, we think that, well, these have been validated time and time again. these numbers are 80, 90% or more. But in actuality, this study is saying, no. And in fact, when they looked at 1,567 eligible interventions, only 5.6%, 5.5% had high quality evidence in their outcomes. But interestingly enough, nearly 10% of the approved medications were found to have significant evidence of harm. So more than almost double was harm found compared to the benefit based on high quality evidence. Just really interesting. And one of the lead authors in this actually name quoted, linked to the article quoted versus the others. It would, they didn't have the names quoted, they didn't have links to the article quoted. But here the author said, if the harms, actually here when we look at this, the harm of the healthcare interventions are superseding and overcoming the benefits. But the author of the study actually said that, look, I don't even think that one can provide informed consent based on this evidence that we're now uncovering. So this is Oxford University looking at a broad spectrum of studies, finding very poor, high quality evidence supporting the predominance of standard of care therapies. In fact, more, 10%, are showing significant evidence of harm. And this author is saying, I don't think docs can provide informed consent for therapies for patients. That's a wow moment. That is really, it's shattering the paradigm of what I think physicians think we are and where we are in statistics and numbers and science and medicine. And I think it's also a way for patients to be empowered to understand where things really, really are. And they're not where we thought they were. So here's the study itself, Endpoints in Clinical Cancer Trials. I encourage you to check it out. Always, when I see a press release and it doesn't link to the study, then I look at it as, okay, they clearly don't want me to read this for myself. And trust me, I scour the internet. And if it's not there, then I really call into question the validity and the strength of the statement that's being made there in a press release. But here's actually the study, and I encourage you to check it out and read it for yourself. So I think what this should do is really present some questions about numbers, about data, about statistics that everybody, doctors included, need to really think as it relates to medicine, science, and what we're doing to treat patients here with cancer. So, first question, is medical research unbiased or is it biased? When is a number just a number? When you look at this reminds me of an old marketing campaign of dealing with low testosterone. I think maybe 10 years ago. The marketing slogan was "Know Your Number," and I thought that was silly because what does the number mean? You don't know the context of the individual. You don't know the context of where their numbers have normally been. What's normal? I mean, it was a silly marketing campaign, but it really stuck with people because they thought, well, if I know my number, I'm going to know what the results are. So how about this? 1 million. What about that number? Most people are going to think, wow, $1 million in my bank account. That's a number. But what if it was $1 million in fine? What if it was $1 million in debt? See, the number itself doesn't provide any really clarity unless it's provided in the context in which it is intended. So if you take a number and put it in a lie, in most cases it's going to support a lie. Likewise, if you put it in truth, it's going to do more to support the truth. So I think we have to really understand these numbers not just as actual factual or definitive truth. They can themselves be a means to, unfortunately, propagate mistruths, misinterpretation, mispresentation, and outright lies, unfortunately. So here's another example of a number being a little bit misleading. When you look at a simple hysterectomy, so when a woman gets her uterus removed, statistics tell us that 0.6 to 1.6% per thousand procedures in women will result in a death. So about 1% per thousand procedures. Now, that sounds low, and it is. But as a whole, simple hysterectomies are very safe. But I can remember a case of a colleague of mine back in the early 2000s. It was somewhere mid-December. A young woman, married, 2 children, went to have a simple hysterectomy for a benign uterine condition, and she coded on the operating table and she passed away. Now, can you imagine those children saying, well, it was just 1%, or that husband saying it was just 1%? No, to that husband, to that family, to those children, that 1% was more than 100%. So statistics, again, they have to be put in the proper context to provide clarity. So can we trust the research, or can we not? When you look at a lot of research today, a lot of it's this press release, hyperbole, and about every year or two, there's a cure for cancer coming. I mean, a couple years ago, before COVID, it was some therapies coming out of Israel, a study that suggested a cure for cancer. So this happens repeatedly. It's over and over and over again, and it doesn't mean that these therapies don't help. It's just we have to recognize the fog and work way to find the true, real science there. Here recently, we've heard a lot of people talk about experts and trust the science. And so what I've seen in science and medicine particularly is a move away from actual talk about studies and just experts. And what's really interesting about these experts is they're never really identified, or they're described as independent. And they don't ever present the science or the background for why they're experts. So when we look at typically who announces people as experts, it's actually usually not the individual doing it. If they do, my goodness gracious, that's arrogant. But usually it's the press, the media, the person doing the interview. They describe the person that they're interviewing as an expert. There's no guideline. There's no, expert panel within medicine that describes what is an expert and what is not an expert. They're just declared. Other also is the use of the independent. I mean, let's be honest. None of us are independent. We're all biased. And in medicine, and in particularly research, when you incorporate fundings, associations, research, flow of money, prestige, publications, all of these will destroy true independence. So whenever you see a study that says independent experts and it doesn't identify anybody, just like it doesn't link to the article, now it's like, well, who is this person? What's their credentials? Why are they an expert? How are they independent? Because let's be honest, I'm biased. I think integrative cancer, holistic cancer treatments are the way to go. I mean, we're all biased. And so that's just recognizing who we are. And so when you look at a lot of the evidence today, a lot of it is more, in terms of research, more political theater. It's to create a title. It's to create clickbait. And you see that in those previous examples that I made. That I showed. It doesn't mean that there's not good science and good science that will come out of that. It just means a lot of it is really just to draw attention, to maximize short attention spans that are present. So a lot of what we see today is more political science rather than evidence-based science. Again, it's merely just medical clickbait, but unfortunately when they don't clickbait through to the scientific article itself, it's hard to really know whether there's science there or not. Here's an interesting question. Again, some of these questions have actually come to me from patients. Do doctors know the science? Do physicians read? I've referenced this quite a bit of times. In 2001, there was an Institute of Medicine article that were looking at physicians, at where they were practicing, so what level were they practicing, and contrasting that to where the current published science was. And they found that physicians were practicing on an average 17 years behind the current published research. Most patients should assume that when a patient goes in to meet with their doctor, that doctor is upfront on all evidence as it relates to their condition and what's going on. Unfortunately, what this medicine from some 21 years ago shows that that is not the case. And in fact, I'll present an article at the end where there's a quote from the author there. It says, doctors are not generally actively involved in research. They may not critically appraise research articles, and their knowledge of recent advances in their field may be out of date. And that was 10 years ago. So most doctors, as it relates to science, are conditioned. And a lot of this is the product of continuing medical education. And what I mean by condition is, I'll give you this example here. I met a great doctor one time, really good doctor at a conference I was speaking at many years ago. A family practice doctor. He was overseeing 4 clinics in the small town that were run by a nurse practitioner. He ran his clinic, and so he supervised 5 clinics. And I had mentioned in my speech that I try to read 3 articles a day. And he said, wow, he said, how do you do that? I said, well, I just schedule in my day. And I said, well, you oversee 125 patients on an average per day. So that's 5 days a week. That's a lot of patients. I said, how many articles do you try to read? And he said, this statement has stuck with me till that time. He said, in my 25 years of clinical practice, I've never found the need to read 1 study. So here's a good family practice physician. He wasn't reading any studies for 25 years. And he's governing 5 practices that basically sees about 125 patients a day. Now, what he was doing is he was reading just guidelines. He was reading expert opinions. He wasn't actually reading the studies. So if the expert opinion was flawed, then his use of that in his clinical practice also, too, was conditioned to be inaccurate and false. Is the science decided? Is it definitive? Now that's something that's been kind of bandied about over the last few years, is that the science is the science. It's solved, it's decided. It's interesting, it's always politicians that do that. But from a science perspective, scientists know that knowledge change. Our understanding of how things work change. I mean, vitamin C in the treatment of cancer is a perfect example of that. Linus Pauling and Ewan Cameron back in the 1970s, they did their 2 such studies in 1976 and 78, where they looked at IV vitamin C 10 grams, and they found prolongation, statistically significant prolongation of terminal cancer patients at 1 year. Then the Mayo studies come in 1978 and 1985, and they say, well, we're going to do this orally with vitamin C, and we found no benefit. That narrative has existed to today. Now, over the last about 10 to 20 years, tons of science is coming out saying, guess what? Guess what? Vitamin C, when used IV, when used pro-oxidatively, is directly cytotoxic to cancer cells. And you can use it to augment conventional cancer therapies. So is science decided? No. It's going to change as we understand more about that. So when you look at the actual word alternative, which, for example, vitamin C is described as an alternative therapy, today it's more of a means to marginalize, not a means to really describe its function. Interestingly enough about that, one of the more original definitions of the word alternatives, the root words, means reporting to be superior choice to what is in general use. Thought that was interesting. So here's the definition of a word that's really gotten turned up on its head from its original definition to today. So in science today, a lot of what we're dealing with is more support for the determinative or definitive outcome that's desired, rather than simply asking a question and seeing through scientific studies what are the answers. One should lead with the science. One shouldn't direct the science to present the results that you want. So here at Brio-Medical, as medical director, we lead with the science. We lead with the science in holistic and integrative cancer therapies. For example, nutrition. There was a June 24th, 2022 study just came out looking at nutrition, particularly Western-style diets, showing that those people that ate a typical Western-style diet had an increased risk of colorectal cancer. Particularly, they also had an abundance of what's called a PKS plus E. coli type of bacteria. And this produced a metabolite called colobactin, and this actually caused DNA damage and was contributing to colorectal cancer. That's the science. Interesting. Diet affects gut bacteria, affects cancer risk. We know this also applies to treatment success. Diet improves chemotherapy. Diet improves radiation, and it does so through the effects with the gut bacteria. So, contrast to that negative, how about a positive? You add more fermented foods in your diet, it increases the production of Lactobacillus rudii, which increases the metabolite ruterin, which inhibits tumor proliferation and tumor volume in vitro and in vivo studies. So the point here is we're going to follow the diet as it relates to nutrition. So what are we going to do? We're going to cut the meats out of the diet. We're going to add fermented foods into the diet because that's what the science says. And we do this as it relates to high-dose vitamin C, as it relates to insulin-potentiated low-dose chemotherapy, as it relates to immunotherapy, as it relates to hyperthermia, as it relates to peptides, both targeted and customized. And we're even involved in research because we don't want to just have to work our way through the fog of research. We want to actually add to the research to actually help improve not just patients' lives, but help doctors be able to impact more patients' lives. And in fact, the future is precision cancer care. And that's what I call the omics, which is genomics, epigenomics, transcriptomics, proteomics, and metabolomics. And these are all aspects that we want to follow the science in to improve precision cancer care in patients. And that's really what we're trying to do here at Brio. And that's what we need to try to be doing throughout medicine as it relates to science. And there are many out there that do that. So hats off to them. But unfortunately, a lot of what's happening in science today is not meeting those standards. Do doctors know the science? Well, I think the answer there is obvious. If they're not reading, they don't. But they can also be reading compendiums and expert panels and these kind of things. But that doesn't necessarily mean they know the science, because if they're not reading, then they won't know. Actually, I think I went backwards. Yep. So our conventional medical therapy is all supported by high quality research. Well, I touched on that. That's the Oxford University study. It's saying that 95% are not. So it really questions the decision making that's being done amongst a lot of the therapies today, because studies are really showing that a lot of the medical therapies today are not based on solid data. And again, the last couple of years, I think, is proof evidence of that. But that's out of Oxford University. It's not some throwaway journal. It's not some throwaway university. Very prestigious, very considered conventional, worldwide respected. But this is not new. A former British Medical Journal editor, Richard Smith, some years ago said that, quote, 5% of published papers reached minimum standards of scientific soundness and clinical relevance. And in most journals, this figure was less than 1%. Whoa. I mean, less than 1%. I mean, that's really just says a lot of what's out there is trash. And in fact, when you look, and I'll show you in a slide in a second, a lot of this data has been retracted. It's been removed from the public record because it's been found to be fraudulent. So let me give you an example. Not fraudulent, but maybe misinterpreted. There was a study that came out a few years ago. They looked at a drug called Avastin that was combined with chemotherapy, and they found that this provided a significant improvement in overall survival. So there was a rush to get this to the market. Then what happened is additional studies that were not using that were using really good clinical outcomes and endpoints, they started to find that yes, there was significant improvement benefit in patients, but it was much less than what was seen in that original rush to judgment article. And also there was a significant increase in harm that was not reported in the original article. And then eventually what happened? That drug was removed from that indication for patients because the actual data showed that, hey, the adverse events were too high. The actual benefit wasn't really in overall survival. It was only in other surrogate clinical endpoints, which have very poor clinical validity, meaning there's not really any science to say they're valid for what they say they say. And again, that article from talking about chemotherapy, where only 3 of the 22 cancers from 2004 did the actual benefits in 5-year survival reach 10%. I mean, who's going to get on an airplane next time the pilot comes on and says the chances of us reaching our destination on time or at all is 10%? Who's going to stay on that airplane? But really, when we look at these numbers, this is what the numbers are saying. And again, to be clear, looking at all of those 22 cancer types with full dose, maximum tolerated chemotherapy in these patients, these 22 different cancer types of these patients, 2.3% of 2.3% benefit was found in Australia and 2.1% was found in the US. So these are small, small numbers. But these numbers are all open to misinterpretation and misrepresentation and interpretation bias, especially when we talk about 90. So when somebody calls and says, well, what's the number? What's the number of success? Well, what is the definition of success? And what is the data? And what are the clinical endpoints that have helped to determine that? Because if there's no solid data, if there's no good clinical endpoints that support those numbers are invalid. And that's irregardless of whether the numbers are true or lies. So our alternative therapy is deemed alternative simply because they have poor quality or no response or nor adequate data. Well, interesting point here is that Oxford study was saying that there's really not that good a quality in conventional cancer care, so in conventional medications and therapies. So alternative might be needed to apply to those therapies because of the poor quality of data there. But again, really what we're looking at here is more of a marginalization term that is alternative here to really skew people away from particular types of treatments. And what they mentioned, for example, in that article talking about the multivitamins, they talked about the magic bullet. And they said, look, we don't want patients to turn to a magic bullet. And what they were saying was they don't want patients to turn to a magic bullet that's not their magic bullet. Now, there's no magic bullet, okay? There's no magic bullet whether it's a multivitamin. There's no magic bullet whether there's nutrition or IV therapy, holistic, integrative, immunotherapy. There's no magic bullet in what's causing cancer or that which will heal it. That actually goes back to Paul Ehrlich. He was actually considered the father of the origin of the magic bullet theory back in treatment of syphilis. But the magic bullet is really it's a bygone thought about how cancer develops or how cancer or disease can be treated, and it doesn't exist. So when you look at alternative, many think that alternative treatments are looking at a magic bullet, but conventional magic bullets work. It's just the alternative magic bullets don't. No, neither magic bullets work. Neither magic bullets apply. So in essence, what we're seeing is we're seeing a lot of really what represents as maybe research or press releases of research as really more just propaganda. And again, propaganda itself doesn't necessarily historically mean something negative. It's only been recently that propaganda has taken on a negative context. But here, propaganda is any movement, organization, material, or information used to propagate some practice, political viewpoint, or ideology. So if you're propagating something that's not science, but you're propagating maybe something that supports politics, ideology, or money, or profits, then it's something that is not necessarily promoting truth. It's just propagating a thought, an ideology. So how does medicine define an expert? Kind of mentioned that earlier. There's no clear guidelines or definitions of how one is to to determine an expert. It's kind of like what I call the weatherman principle, which is they're always the expert on the matter, but they're never right on the matter. It's the one area one profession where you can be wrong 100% of the time and still have job security. And they're always unanimously ambiguous. These experts are really never typically identified, and their status of experts, or how they achieve that, has also never been clearly identified. So again, whenever you see somebody describe what's expert opinion, it's independent expert opinion that's describing this process. First, look to see the article, read it for yourself. Second, always question medical expert or this kind of ambiguous presentation of data strength. And really just look at the track record of the last several years. There's been more wrong by medical experts than there have been more right. And though it could be right in the beginning, New data may show it's now wrong. So it's about being in the science, not just following somebody telling you to follow the science when they won't present the science or discuss the science. So about knowing the context of the statement, the context of the number, the context of the statistics will help you better understand the validity of them. So finally, is evidence-based medicine evidence-based? Well, the former editor of the British Medical Journal, Richard Smith, really cast doubt on that, saying that most journals, the figure of published papers reach minimal standards of scientific soundness and clinical relevance was less than 1%. That can't be used to provide evidence-based guidance. When you look at the actual numbers that they found retracted over a 10-year time frame, you extrapolate that out from 1950 to 2004, you find that roughly 10,000 to 100,000 articles, studies, are retracted because of a wide variety of reasons: error, fraud, falsification, inaccurate conclusions, poor study design. And in many ways, a lot of what's being done to kind of standardize medical education is creating a problem of more groupthink rather than critical think. And so this continuing medical education that is born out of the medical education process, it's creating a lot of this problem. So most physicians, let alone patients, they're not critically analyzing the data. They're not critically analyzing the number. They're not critically analyzing the statistics. And so as Mark Twain says, hey, they're malleable, they're flexible, they're influenceable, and really then make statistics more of a reason to propagate maybe something that's not necessarily true or maybe not necessarily effective. So is informed consent evidence-based, or is it not? Again, the Oxford article says, no, it's really hard to say that we can, in an evidence-based manner, provide informed consent today. That's the lead author of that. Now, I'm sure there are those out there that would disagree with that. And that's the great thing about science is about the open debate of ideas. We can come together, debate the science, and disagree. Science is not uniformly agreed upon. No matter how many media people say it, everybody is going to bring different bias and interpretation bias to the table, and thus different eyes and background provide different insights of that data. So again, there's a lot of reason to speculate that a lot of informed consent today, based on lack of high quality data, poor evidence, poor reporting of adverse events, because studies have looked at the reporting of adverse events. Less than 10% of adverse events are reported. So we're really looking at a problem where not enough of the adverse events or side effects associated with treatments are reported. And if you can't focus or provide clear data on the adverse events or side effects, you cannot provide informed consent. You just cannot. So is it possible? I think a lot of data is really pointing to the fact that we need to reconsider how we analyze data, construct data, and use that for informed consent. When you look at most medical research today, most of it's intended for profit. Most of it's retracted. Very little of it's read by physicians. It takes at least 17 years to reach clinical practice. Most of it provides little to no clinical benefits in patient care. A lot of it provides side effects. And that's where we are. That's where we are with a lot of the evidence. And I don't mean to cast a dour look on it. It's just understanding where it is. Focus on the numbers, focus on the studies, focus on the statistics, read it for yourself. Look at the clinical study design, look at the clinical outcomes, look at the powering, look at the statistical analysis. These are the best ways to really try to inform oneself about the data. Don't read the press releases, don't listen to some bureaucrat or some media person behind a desk telling you what the evidence says. Read it for yourself. That's really where the empowerment of what consent or evidence-based data can come from. So in closing, this was part of the conclusion from this 2012 article that I referenced earlier. Now, this wasn't a study, but it was just an assessment of research and the quality of research. And so it basically falls in line with what the Oxford study talked about. It falls in line with what the former British editor talked about. And I think it's really important to read certain parts of this. First is, you can see there, doctors are not generally actively involved in research. Let me smooth this out of the way. I can't read that because that is in the way. Okay, here we go. Doctors are not generally actively involved in research. They may not critically appraise research articles, and their knowledge of recent advances in a field may be out of date. Again, even that Institute of Medicine article said doctors don't read. It's just simply saying what all these other articles have said, is that doctors are going to read the press releases. They're going to hear the press reports. They're not going to go find the study and read it. They should. They should be actively involved in research, but most are not. A vast number of research papers are published every year, and most of these have significant limitations, and some poor science may even be published in the most influential journals. 2 articles have said that. Publishers and manufacturers of pharmaceuticals have sometimes colluded in ways that do not necessarily benefit patients. So here it's not to point fingers, it's just to recognize that this happens. Medical publication is an industry. It is a business. And so unfortunately when money gets in there, it tends to create bias. And that's where I talked about independent experts. If money's involved, then it's probably not going to be an independent expert. And then finally, much of the most generously funded research is aimed at long-term commercial goals rather than benefit patients. That's our goal. Our goal as physicians, especially here in the treatment of cancer, is to help patients heal. It's to teach patients how to heal. And in that process, we need to make sure that everything we're doing is focusing that on. Much of what we're dealing today is more advocacy confusion because doctors are forgetting who we serve. We serve patients, and that's the only who we serve. We don't serve insurance companies. We don't serve hospitals. We don't serve governments. We don't serve organizations. We serve patients. That's who we take our oath to, is to help teach and heal patients how to heal. So thank you all. This is just the contact information. Like I said, I'm the medical director here at Brio-Medical. I encourage you to check it out. Again, I don't want to cast doubt on research, science. I love it. All those that are involved in the bench research and do great research across the world, I'm a champion for all of them. It's just what's happening a lot today is really too much of a rush to publish, too much a rush to get something out in the market, and not enough data, both in effectiveness, or maybe the data is even poor in the effectiveness, or the quality of data is poor, or the adverse events are not even reported. And so what we see is a lot of patients harmed that shouldn't be. So hope this has been helpful. Let's look into the chat room here. So here's a question. When a natural clinic says they have a 90% success rate with XYZ cancer, what does that mean? Well, if they don't define what that means, then I don't think you can take that with any validity. So the perfect example there is what I talked about as it relates to the adjuvant chemotherapy study from 2004. If you just simply said 13 of 22 cancer types have benefit, are successfully treated with adjuvant chemotherapy, and you don't define what that means, you wouldn't know that really it's like 2.1% improvement in 5-year survival benefit. And so if they don't define what those clinical endpoints are, if they don't present the data that support whether that clinical endpoint is validated, very interestingly enough, one of the most common surrogate clinical endpoints is what's called progression-free survival, or disease-free survival, excuse me. And there's only one aspect of that that's been clinically validated. That's the use of 5-FU in the treatment of colorectal cancer. Beyond that, using that surrogate clinical endpoint it's not valid. It's not been proven to be true, meaning what it says it may not be true. Now it could be, but it may not be because it hasn't been clinically tested and clinically validated. So if they're just saying 90% to 90%, they're just, again, numbers support the context. And if the context is, not truth, then it can be used to support that. So without that proper context, you can't take that 90% success rate to mean anything. Let's see. Any other questions? Got more comments, and thank you for that. I think if there's a take home here, I think it would be this. Most of what is presented as research in the news, in the paper, in social media and they're just press releases. And press releases doesn't in essence make them bad. But if there's no context to that press release, just like there's no context to that number, as somebody asked about 90%, what does that mean? 90% what? Cure? Well, you can't say that. It's not validated. 90% reduction in pain? Okay, but I want to get better. That's great, but that doesn't help me. 90% improve in appetite? What does it mean? The interpretation bias, and this is desired and this is intended. Interpretation bias is that 90% is heard and it's cure. 90% cure. But you can't, again, there has to be that context to be able to understand and really give legs to what it is you're looking at there. Well, I hope this has been helpful. And again, if those press releases don't click through to studies, the articles, if they present experts and they don't name the experts and then allow you to link through to their bios and their place of employment, then I think you have to take that with a grain of salt. So, hope everybody's had a great July 4th weekend, have had a great week, and I hope this has been helpful. Check out our YouTube channel where some of our past webinars have been placed. We're going to be trying to do these every 2 weeks to get these out there. We're going to be talking about more treatment applications, but I just thought it was important because of just really some of these recent events that gave us opportunity to talk about the numbers and the statistics and really try to dive into fact versus fiction. Have a great evening.